Small talk video. Only small.
A little quick video.
Just come to my attention. Probably the track officially suffer the most common injury in the game of basketball. Broken ankles. This year at the hospital.
So, in case you can't hear this video, this talk will be about ankle insurance and why you need it. Because basketball season's coming up, and children all over the world are going to start playing basketball. And our first game of intramural basketball today is going to be an influx of patients after the game to the ER with broken ankles. And so, it's important to know about your ankles and how to deal with those radiographs and kind of how to fix them. So, I want to thank this small talk team for forcing me to use Nearpod, and we'll get this going. So I want everybody to kind of just quickly kind of look at their ankles and see some of the movements you can use with it. So supination, pronation, external rotation, kind of think about the ligaments. And because this is, ortho talk, everything in ortho is pretty simplified to them. So all the ligaments are coming from, they're kind of labeled based on where they're attached and where they're going. So, fibulotibial ligaments, besides some of the deltoid ligaments in the medial aspect, different ligaments and what each sort of rotation of the movements and rotation of the movements of the ankles kind of affect. And there's a lot of ways to describe ankle injuries based on the sort of movements of the ankles. There's even more simplified ways, so we'll talk about that today. Just the quick things, if you don't know the ankle sort of anatomy, there's the tibia, fibula, sort of the talus calcaneus, and then all the ligaments involved with it. The main ones are really the ATFL, the tibial-fibular ligaments, and then the deltoid ligaments. So the main part of ankle anatomy that we really need to focus on today, that are mostly affected by ankle injuries. Now there's a couple of ways to classify ankle injuries. First let's talk about the sort of x-rays. How many of you guys have ordered an ankle x-ray before? Great. And so, instead of kind of waiting for the radiologist to read it for you, it's kind of pretty simple to read them if you just kind of dive down and think about it a little bit. 3 different views, AP, mortise, and lateral. And then sort of knowing where each bone is supposed to be in and sort of to overlap the image in and kind of to see if there's any sort of big gaps in the bones. You don't have to worry about the exact measurements, but if you have a gross sort of just look at it and see if there's any sort of widening between the plates, and that kind of will tell you where the injury is. Whether at the talar dome, if it's a little bit more increased than it should be, or the syndesmosis, which is the middle between the tibia and fibula, in this area here, if it's a little bit more than it should be, those will kind of speak to where the fracture or where the injury should be looking for. And ankles are ring structures, pretty much like any sort of bone things. They're stable and unstable. So one break in an ankle is a pretty stable structure that you can cast and kind of have them follow up with the last year ortho. Whereas if there's a 2 break in the ring, that's clearly an unstable fracture. And if there's 2 breaks and clearly at this location, that's an unstable fracture as well, and both of those need to go to the OR. Not immediately, but ortho needs to go and put some needles in there, put some pins in there and screws in there and kind of get everything all fixed up. So think of the ankle as a nice ring structure. If any of that sort of ring is broken in 2 places, that's when you need the ortho. So if you're in a community hospital and you just have one sort of break, you can cast that and have them follow outpatients. But if you see 2 breaks, you call ortho. Pretty much simplified. Major classification of ankle injuries. There's the Log-Hansen and the Weber criteria of identifying an ankle fracture. Weber is a little bit more simple. This is not the person Weber, this is Chris Weber, the basketball player, if nobody knows that. But the Log-Hansen criteria is based on the movements of the ankle. Most of the time, an ankle injury will be supination and abduction, so kind of like twisting your ankle on this side, and kind of that's a majority of the injury that you'll get. But if you kind of move your ankle around in your seats right now, you can see that certain movements kind of are hindered by the anatomy of your foot. So the pronation and internal rotation, it's a pretty difficult movement to do in your ankle. So if that kind of occurs in the mechanism of the injury, you should expect a more severe fracture. And just think about the mechanism anytime anybody comes in with an ankle injury. If they're falling from a depth, if they're from a great height, if they kind of twisted their ankle in a certain way, that's where you're looking at the radiographs. You're looking at the sort of the lateral aspects, the medial aspects, and you're looking for sort of breaks there. Whereas the Weber criteria is pretty simple. You have your fibula, and this depends on where it breaks. If it's below the talar dome, this is the talus. So if it's below the talar dome, it's a Weber A. If it's with the talar dome, it's a Weber B. And if it's above the talar dome, it's a Weber C. That's the main one that we should be using in the ED. I mean, let's think about the microhazard criteria, but Weber criteria would be a little bit more simple for us to use, kind of just to, when we talk to ortho about it, hey, this person has a Weber C fracture. He needs to come down and see him. Kind of simplified talk. And then each of those fractures are associated with different sort of injury and have different stages, but we don't need to focus too much on that. It's more ortho kind of classified. Let's talk about our first fracture. So this lady clearly is not having a good time. So if we look at the mechanism of her injury, she has a little bit of a supination and abduction in her ankles. Can anybody point to the fracture? If this pointer worked, this thing over here. And out loud, anybody can say what that is in terms of Weber? Weber A. Thank you, Ronnie. We just finished this ortho shift like 2 weeks ago. So this is a stable fracture. There's only a fracture over here. It's a Weber A. You can put her in a short leg cast, and you can have her follow up with ortho. Whereas this dog is not having a good time. So weirdly, this dog has regular foot human ankle anatomy, and as we see, fractures over here. This is a Weber B. Weber Bs are usually spiral. They're usually at the level, kind of break at the level of the talar dome. And the reason for that, if you think of the mechanism, it's a little bit more of a pronation and abduction. And so the ankle's kind of moving a little bit more this way. And you have a push and pull give in your ankle. So when you're sort of pulling away, you're having a more transverse and spiral fracture. And so this is what kind of causes the Weber B fracture. You can also see a little bit of a avulsion, which this is shown here. On different views, you'll see a little bit of a fracture here as well, which is kind of typical in Weber B fractures. And then the more severe fractures are, if you look at this lady's left foot, she clearly is not having a good time. And so both ankles are probably broken, but one of them is probably worse than the other based on the mechanism, because one of them is just kind of a simple supination and abduction, the other one's a little bit more of a pronation and external rotation. So I can assume that her right ankle has a Weber A fracture, and her left ankle probably has a Weber C fracture, which is a little bit higher up in the talar dome as we see here. And then again, a avulsion of the medial malleolar. And in more recent news, if anybody follows the New York Giants, Odell Beckham Jr., if you look at his right foot, or left foot, you can see the mechanism here. Anybody want to guess what this is? Huh? So if you look at this x-ray, really what's only shown in this x-ray is this. There's a posterior malleolar fracture. Now posterior malleolar fracture by itself is kind of rare. And it's usually like 25% of the cases you'll get it. And these are usually stable fractures if they're not too displaced. But if you look at the mechanism, I want you to think about more than that. I feel like might be missing stuff, and you just see the posterior malleolar fracture and then kind of end there. You can actually see a little bit more swelling on this lateral aspect here. There's also a little avulsion here. And one of the other things, ortho always asks for completion films, which they're actually right at this time. Because he probably has a Weber C fracture, because just based on the mechanism, he probably has a Weber C fracture. So you want to look at where the actual fracture of the fibula will be. Because you really don't see it on this image over here. But if you do completion films, I wonder if you guys have something on your phone right now? Say some drop.
I just had to hold on back in junior. Slide.
All right.
Okay, now I'm ready.
So, he has a fracture a little bit above, which is called a Mason-New fracture. It's still a Weber C fracture. It just doesn't necessarily have to happen right next to the ankle. Because there's a ligament kind of in the middle between the fibula and tibula called the synosmosis. And so the mechanism of the fracture causes a tear in that ligament, and then the fracture can be even higher up. So it doesn't necessarily have to be at the level of the ankle where you just see ankle films. So it's always good to get your completion slides, completion films, and see if there's a fracture above up, because this is technically an unstable fracture. He has a posterior malleolar fracture, but also has this fibular fracture. And then since there's some Pete's fellows in the back, I figured we'd talk a little bit about Pete's fractures, and kind of the most obvious ones that we usually cover every day today is the Salter-Harris. We all know the acronym, so I'm not going to speak too much about this. Where it's kind of looking normal, above, below, through, and then kind of completely destroyed. So take some time, I think on your phone right now, it's going to be a couple of seconds to look at this fracture, kind of draw where the fracture is and what kind of fracture it is. If this is working. Let me know if it's not working. You guys able to draw?
Yes, sir.
So you can see it populated, some of you are still drawing. We can go through some of these drawings from I Love Mo. Clearly, those are the right fractures. Weber C. This person gets the Weber C. Let's see if he's right. Surprising with this one. Good. So this is a Weber C fracture, as Stacy, unhappy face, believes. The sailor said as well. Unstable fracture, and so this requires fixation by ortho. Next image. Where's the fracture here? Give you guys some time to draw. fracture here. This is somebody's dog. That can work too. But no one's guessing sort of what type of fracture this is. So I would argue the sort of the middle, if you look at the space between the tibia and the fibula, that's a little wide. So again, I wouldn't settle for just an A. I would think about maybe this is a Weber C fracture. Maybe this is a fracture kind of further up. So again, think about the mechanism. You're right, if it was just where it was here, I would definitely say A. But the widening of this distance between the two bones, I would think of a fracture more up, kind of like OBJ's, which again, I don't know if he actually had that fracture, but it kind of makes a new fracture further up. This was a trick question. Where is the fracture? This is a difficult one. So, this is actually me. This is a normal x-ray. There's actually no fracture here. But there's only one view, right? We need other views. So I'll give you another view. So Elfatihi actually has the right idea. Which again, this is not Elfatihi. Not Elfatihi. There's definitely widening between the tibia and the fibula. And there's definitely kind of a gross abnormality between the actual talar dome and the tibia. So this is probably a Weber C, or a, if you delve deep into it, you probably need a better image to actually see where the fracture is, more views. But I would definitely say this is a Weber C fracture. It's definitely a syndesmosis there, similar to the other ones. And this is one more. If you want to label it what kind of fracture it is, it's W. like most people kind of circled in on these findings here. But I didn't really give you guys a history. What if I told you this person was 10 years old? Right? Are these normal findings on a 10-year-old? This actually is a pediatric fracture, or a pediatric X-ray. There may or may not be a fracture here. This is kind of a Salter-Harris one. If he has tenderness where, in the middle of the pain, where that's the area of tenderness. Otherwise, if there's no tenderness, this is probably a normal X-ray for a person of his age. Because this is just the growth plates on both sides. This is an adult. Yep, so Chris points to our fractures. There's clearly a fracture above the patellar dome. There's a posterior malleoli fracture. This is a Weber C fracture as well, so this needs, again, an ortho to come in and pin some bones together. This is an unstable fracture. And then again, I want you guys to think about the mechanism. This is a quick video for the next slide. I don't know if you guys seen The Office. This is an episode where they try to do parkour. Things don't end well for Andy. So if you think of the mechanism, fall from height, can you draw where the fracture is? So this is pretty straightforward actually. There's a fracture all over the place. This is called a pylon fracture. It's pretty much a severe fracture due from height. It involves the breaking of the actual